Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
I want to turn to our morning keynote. Our speaker, the director of the Department of Healthcare Policy and Financing, Bimestefer. I always say that incorrectly. Kim, sorry. Kim Bimestefer has been not just a leading force in reform in Colorado, which if you know the Polis administration, if you know Kim, you know that she is a dynamic force. But we have the honor of working in 9 states. We're expanding in 2021 into 6 more. And I don't know of anybody in any of the states in which we work or any state level healthcare agency leader that of which I'm aware. I don't know of anybody who is pushing as hard and as fast as Kim is. And while that might make some folks uncomfortable, perhaps rightfully so, it is clear that we do need to move a little more quickly than we all would like in healthcare to get to where people want us to be. So with that, Kim Bimestefer, thank you for making time, Kim. I appreciate you being with us. Let me turn it over to you, ma'am, and I'll pull your slides up here so you got them, and then you can take it away.
Excellent. Thank you, DJ. Folks, it's an honor to be with you here today. Really appreciate the time and everybody's engagement. DJ, it looks like it's having a little problem. There you go. So we can't talk about healthcare and the state of healthcare in the state without talking about COVID. So let's start there. And we're going to start with a wake-up call and a call to action. The surges that we're feeling across the country and here in Colorado are at the level that we must have action from everybody in order to avoid catastrophic results. So the chart up to the right-hand side shows the escalation of cases. We continue to break records in the escalation of cases day after day, week after week. We now have about 1 in every 110 Coloradans are contagious. In the more densely populated areas like Denver, 1 in 64 individuals are contagious. What does that mean? It means that the surge that we are experiencing, if we don't interrupt it and curb it, that the hospital systems themselves cannot meet the needs of all Coloradans. In other words, the hospital systems will breach. So we all have to take action, and we are taking those actions. The hospitals, at the direction and in collaboration with the governor's office, are augmenting staff, increasing capacity. We've turned on the Emergency Operations Center at its highest levels. We've also established alternate care sites in the event that the hospital systems breach. We can potentially open up to 2,000 beds inside the Colorado Convention Center. I want to thank Robin Wittenstein and Denver Health for stepping up to oversee the clinical application, the clinical delivery of care in the Convention Center. We can also open up a possibility of 200 additional nursing home beds in Pueblo and in the Denver area in order to absorb that additional surge if the hospital systems breach and the nursing homes breach. Here's the challenge. We have a workforce challenge that we can't find the workforce in the same way that we could early on in COVID. If you remember early days when we were all watching in horror, New York not being able to meet the needs. We have people from all over the country going to help from a healthcare delivery perspective in New York. Now we've got a surge all over the country and we can't pull from other states in the same way that we could. The other thing that we're doing is recognizing that certain folks inside the populations in Colorado and across the country are more vulnerable to COVID than others. And the most vulnerable among us are those that are in residential-like settings, residential congregate settings, which would be things like nursing homes or assisted livings. Those are individuals who are seniors and are individuals with disabilities. So the good news, that strike force, which is co-chaired by our department, leaders in our department, and Public Health and Environment, has received AARP recognition as the model across the country for others to follow. And we are so proud of that. The results of it are outstanding and exemplary. However, the reports that we get every week as leadership, I wanted to read you this statement that is catastrophic. This past week brought startling increases in almost every tracked category. And we need to be aware of that. And we need to take action because more than 60% of the deaths in the state due to COVID are in these residential settings, these residential congregate settings. So what can you do to help? And we do definitely need your help. The first three on this slide, you have heard of: socially distance, wear your mask, wash your hands, please. This fourth one is new to you and a little bit more difficult. During this Thanksgiving season, we need folks to congregate and celebrate only with their immediate households, as specifically defined as those who lay their head in the bed in that household every night. Now, why do we need to do this? Wednesdays before Thanksgiving are the most popular travel date of the year for Americans. If we have that same behavior here in California and across the country, the surge we will cause the healthcare systems to breach. So what can you do? Be a leader. Send the messages to your own family. Change this year's tradition, please. Celebrate remotely. And help us spread this word by sharing this public service announcements of Dr. Rachel Herlihy, and also share the 2 exposure notifications and the Step Up campaign to help us slow down the spread, please. I want to send out a special thank you to our healthcare workers. You have gone above and beyond. We know you're tired, but we are so appreciative of everything that you do every single day to take care of all of us. You are an example of what it means to be a public servant and a servant to the communities. Thank you for everything you do. And a special shout out to our hospitals. Your leadership has been superior across the country, and we owe a debt of gratitude to everything that you're doing, as listed in these bullets, to help from setting up models to being recognized nationally for our chief medical officers helping move us forward and develop best practices to save lives. You are the difference maker, and we are deeply appreciative. I also want to address the ACA. We're talking about the state of healthcare. The ACA is the biggest piece of legislation that has passed since Medicare and Medicaid. Now, big parts of it help care be more affordable to Coloradans. There are 600,000 Coloradans that have healthcare be more affordable to them through 2 parts of the ACA. One is Medicaid expansion. The second is the federal subsidies that are available to the Colorado Connect for Health Marketplace Exchange. That's for individuals and families who are purchasing coverage. So 600,000 Coloradans get their services there. We also get about $2 billion from the Fed to help pay for Medicaid expansion. There are other areas of the ACA that I'm sure you're familiar with. You might not be familiar with the fact that reinsurance, that program that Commissioner Conway put through with our elected officials in the governor's office, that lowers healthcare costs for individuals on that exchange by about 20% across the state. It's actually funded through the ACA. So here is some optimism, cautious optimism, that the Supreme Court justices, questions that they were asking during the November 10th hearing on the ACA, make us cautiously optimistic that there will not be catastrophic consequences that come out of their rulings. For those aspects that are impacted, we should have some bipartisan support in order to work through whatever those adjustments are. The state is already contingency planning, and the Biden administration is also ready to step up. So let's move to the economy. 672,000 Coloradans have lost their jobs and have filed for unemployment insurance since the COVID pandemic and economic downturn started. And you can see on the left-hand side of the slide the consequences of the rising unemployment rate. But you can also see it ticking down in July, August, and September. Some of that is great. I'll touch on the next slide, how that people are getting their jobs back. Some of that is scary. It means the denominator is changing. Women are dropping out of the workforce because they're trying to balance working with childcare, and some of them can't find that balance, so they're dropping out of the workforce. The second point of concern that we need to address is this downturn in the economy is not hitting people equally. That bottom blue line says that those of lowest incomes have a 25% unemployment rate. So lower income people are getting hit the hardest, and women, from this downturn. We need to recognize that. So if 22% of the population has lost their jobs, the hardest hit are those in the lowest wage workers. Here's the good news. On the left-hand side, Colorado is surpassing the rest of the country in improving and coming out of this recession. I want to thank our governor's office. I want to thank all of the employers that are working so hard to do this. So our recovery rate is about 66% compared to the nation's 54%. But what can we do in addition during a time of tremendous DC gridlock? We won't see stimulus dollars come out till at least after Biden is sworn in, and we can get through a process with the new House, new Senate, new administration. So we have some time we have to get through. So what can we do in between? The governor's new budget that just came out a few weeks ago includes stimulus dollars in the amount of $1.2 billion That is the first, at least in my Colorado history, that I have seen a governor rise up so boldly and act when the federal government will not, and bring stimulus dollars to Colorado to continue our trajectory of having an outstanding economy to help people recover with an eye towards those of lower income. We've listed a bunch here of that budget. I won't go through a ton of that, but know that there is from broadband to infrastructure and transportation to one-time stimulus dollars that go to families making less than $52,000 first week of December. Each one of those families that filed for unemployment making less than $52,000 will receive a check for $375. So lots of stimulus dollars to help us have a bold economy. So one thing that happens during a recession, people lose their employer-sponsored coverage because they lose their job. So we're seeing a dramatic increase in the Medicaid enrollment. So that blue bar is kiddos and their increase, and the red bar that is the steep increase, that is adults in expansion population that have lost their jobs coming onto Medicaid. Good news, federal government has provided $565 million so far to help us cover the increasing number of Coloradans that need coverage. And while those are impressive increases and the department is stepping up to help, it's not nearly as high as we thought it would be. So we did some surveys in collaboration with the Department of Labor and Employment, and we asked some questions to those on unemployment insurance. Where are you getting your coverage? And 19% of those said, I don't have any coverage, and that was concerning. We also asked them the question, what do you plan on doing relative to coverage? And 46%, almost 15% of the 19% said we plan to stay without health insurance coverage. That is concerning. So we are studying that. A survey went out about a week ago. We'll have those results in another week. But we have some assumptions because of other studies going on. We believe it's because families are struggling to keep a roof over their head, and food on the table. 20% of Coloradans are worried they can't feed their family. 22% are worried about losing their home. 18% can't pay for basic necessities. Our supplemental nutrition assistance program, which is food for those at lower incomes that are struggling, those applications are up by 55% coming through February to April when the COVID pandemic hit. So what do we have to do together? We have to connect people to affordable coverage. We had a stakeholder meeting on September 24th, more than 200 attendees. We came up with some priorities. We have a follow-up on December 3rd. If you would like to take part in that, just send me an email. We will invite you to that gathering. And it's very important work that's going on. The other thing that we need to recognize is the way that people are covered in Colorado has dramatically changed over the last decade. So if you look from 2009, before the ACA, which went into effect in 2014, then look at 2015, then look at 2019, and look at today, you can see massive changes. Look at Medicaid, the blue, darker blue bar, only 9% plus CHIP, about 10% of the population. Today, through this pandemic, we are now covering 24% of Coloradans, 1.4 million people. Medicare is covering 941,000 Coloradans. That's 40% of the Colorado population. The lack of affordability, the affordability crisis is inside the private system, not the public system. So is it time to recognize and have more discussions on a public option that leverage the strengths of the public market and our affordability capabilities to bring those solutions into the private market to help bring care to be more affordability for the betterment of Coloradans, for the betterment of employers, and to further help the state, like the state employees. Regardless of that debate that we can have going forward, affordability has bipartisan and continuous support. So what do we do for affordability to help all Coloradans and the state and employers? We look to what areas are causing the rising cost of healthcare. One is prescription drug. That's the top leading area of a driver. The second is hospitalization, both in spending and utilization, as well as prices. Good news, Lieutenant Governor, is appointed by the governor, has created the Office of Saving People Money on Healthcare. And the first two areas where the focuses are for the goals relate exactly to those two things, prescription drugs and hospital and prescription drugs inside the large group insurance market, which we're trying to control cost as well. So let's hit pharmacy first, or prescription drugs. So we know on the right-hand side, this country has the highest costs in the world for prescription drugs. On the left-hand side, what we might not realize, most might not realize, is the highest cost drugs in this country, and here in Colorado, which the left hand represents, 2%, less than 2% of the drugs prescribed by physicians to treat their patients are so expensive that they're now consuming 49% of the total spend in the state on the commercial side. And by the way, that mimics Medicaid spend as well. The statistics I gave you are from 2018. If you push that forward to 2020, my guess is that is well over 50% now. But the issue is rising prescription drug costs are driven by brands, generics, and high-cost drugs. So we need to address all three with a special focus on high-cost drugs. So what can we do to address all three? One is we can import drugs from other countries. There will be a report issued next month by our department that gives a full analysis, but I'll give you a heads up on what it says. If we import drugs from Canada, 63% savings on those drugs. That includes maintaining the profits for those here in this country as we import those drugs. 84% if we imported from France, and 78% if we imported from Australia. If we imported some of the what are called biologics, those are drugs like Humira, the #1 selling drug in this country, or insulin, the savings are higher as a dollar amount and in the same range from other countries. A grand opportunity for us to focus on. What also can we do? Rebates and other compensation that happens between manufacturers of prescription drugs and the commercial carriers. The dollars associated with that represent about 18% of those high-cost specialty drugs when they set the price, and represent about 22% of the price of a brand name drug that's not a specialty drug. So if we worked more thoughtfully on policy that made sure those dollars moving from manufacturers to carriers kept moving through the system and passed along in the form of reductions in premium rates to or self-funded rates to employers and to consumers, we will be the better for it. So in conclusion, on the pharmacy side, what can we do? Transparency to understand why the prices are increasing, or why the prices are what they are for these high-cost drugs. What are the prices in other countries? How can we help employers negotiate better deals? How can we get those rebate dollars to pass through? How can we import drugs from Canada? And how can we give prescribers better tools to more cost-effectively prescribe? Let's move to hospitals. So hospitals in this country are part of that escalating in prices and increasing in healthcare costs. About a 23% spike across the country between 2016 and 2018. So what's the goal that we can set for Coloradan hospitals? Perhaps we can say, if we use Medicare reimbursements as a baseline, can we challenge our hospitals to work collaboratively with communities to just get the prices down to what the averages are against Medicare across the rest of the country? If our prices from hospitals are higher than the rest of the country, let's challenge and negotiate and collaborate with hospitals all across the state to bring those prices down equally to the rest of the country. And then let's lead. Let's try to bring them more closely down to below averages in the rest of the country. We have a massive range in pricing between hospitals in Colorado. In some circumstances and procedures, it is as much as 10 times different hospital charge per procedure to hospital charge. One of the issues in our state is the same in the rest of the country, in that we have had significant mergers and acquisitions, and mergers and acquisitions across the country have driven hospital prices up and doctor prices up, not down. It's on the Biden administration plan to address the balance of power through these large systems, and we have the same challenge here in Colorado. So in 2009, 7 systems used to own about 26 hospitals. Now in 2020, about 6 systems own about 48 hospitals. So if you were Anthem, who we spoke with, Anthem says of 5 contracts, that now governs 90% of their spend for hospitals and about 50% of the doctor practices and their contracts. So how do we address the transformation of hospital systems? We can see the transformation of the past with mergers and acquisitions. How do we transform more favorably in the future? The good news, our hospital association in Colorado and the hospitals themselves have doubled down and are truly invested in what's called the Hospital Transformation Program. That takes about over $1 billion in payments from Medicaid and gives value-based payments to hospitals for transforming in a way that is to the betterment of Coloradans, Coloradan families, and to our employers. That is a big deal. So it might say, if you close down those standalone emergency rooms, we'll pay you more in value-based payments. If you open up substance abuse treatment beds or mental health beds, we'll give you additional dollars. So how do we help hospitals transform? by creating value-based payments that incentivize them to transform. So they are doubled down on that from the hospitals. We're working collaboratively. We are very appreciative of this work because it recognizes the hospitals standing up to be part of the affordability solution. Inside this HTP is also $60 million over 5 years to help our rural hospitals transform. Outstanding. I want to recognize the hospitals for the outstanding work they've done on affordability in just the last year. I'm going to iterate some of these things. University Health Systems and Sisters of Charity shutting down freestanding emergency rooms. Outstanding. Children's Hospital stepping up. 40 to 70% reductions in unnecessary treatments and treatments and scans. Outstanding. Sisters of Charity reducing in Grand Junction MRIs and CAT scan prices by as much as 70%. A Banner stepping up to be part of the solution. Centura working with Peak Alliance and Southwest Health Alliance partnerships and reducing prices in the 20% range, covering areas of about 7 counties, and dropping charges to self-pay consumers by 50 to 60%. Vail Health, I want to specifically call out Will Cook, a new CEO. It comes into a hospital, sees profit ranges in the 30% range, and says, we can do better. And he steps up and he says, largest self-funded employers, here's a reduction in prices. And individual marketplace carriers, here's a reduction in our prices. And small group employers, we want you to do well, here's a reduction in our prices. That is outstanding leadership. Centura and Vail and Banner and University and Children's, Sisters of Charity. So many hospitals are stepping up. Thank you for being part of the solution. What else is happening? In the dialogue between the negotiations between communities and hospitals, our department has built the most outstanding tools in the country to enable those productive conversations, as evidenced by statements coming out of Johns Hopkins. The best tools in the industry. We'll talk more about them at the 9 o'clock kickoff breakout, but it will enable organizations like the Colorado Business Group on Health, who has also established Colorado Purchasing Alliance, that will help those negotiations, help communities collaborate with hospitals who want to and are stepping up to collaborate back to drive affordability and help them find the best place and come to an agreement on their negotiations. I also want to call out Commissioner Conway working with the governor's office and elected officials to pass the reinsurance legislation, because that reinsurance program is saving about 40% on the western slope and 21% in the individual marketplace, and that is outstanding. Going forward, we can together define a new normal, and that new normal can be about amazing innovations like telemedicine, or repurposing and closing down these emergency room standalones, or giving physicians better tools to prescribe more cost effectively and to improve quality, or improve transparency, whether it's carriers passing along rebates or hospitals in their financials and their pricing, or in prescription drug prices. And we can continue to evolve alternate payment methodologies that reward our providers for the outstanding work that they do and for their ability to drive more affordability. And I'll close my comments with an incredibly important area, which is healthcare disparities, which have been magnified by the COVID pandemic. I want to call out first on the left that we are in the worst 5 performing states for suicide and for alcohol-related deaths. For those of you who have had suicide in your family, as we have experienced, it is an incredibly painful experience that I wouldn't wish on anybody. But COVID has made it even worse. If you look on the right-hand side, the drug overdoses and deaths in all of 2019 were 73, but in May alone of 2020, 128. We have to help people with mental health issues. They are exacerbated through COVID, as we all know. But if we look at specifically what we can do about that, a lot of work is being done. One, Medicaid is covering inpatient substance abuse for the first time in the history of Medicaid in Colorado, effective January 1st, and we celebrate that. We are also giving physicians tools to make sure that they prescribe opioids incredibly carefully, and they are warned when they're about to prescribe to somebody who has a greater chance of being addicted. That goes up and running first quarter. And the Behavioral Health Task Force has been an outstanding collaboration of all different stakeholders across the industry that will improve access, quality, efficiency, and help Coloradans navigate through the behavioral health system. We're very excited to bring stimulus dollars to drive that and accelerate the recommendations of the Behavioral Health Task Force and the Behavioral Health Administration to address these emerging and challenging issues. I want to reference the healthcare disparities and call us all to action. If we are looking at the left-hand side of the slide, If you are a Black woman giving birth, your chances of a negative outcome, in fact, losing your life, are 250% higher than if you were a white woman delivering a baby. That is not okay. And if you are a Hispanic resident in Colorado, you are about 20% more likely than a white resident to die of a treatable condition. That is not okay. And COVID has exacerbated and put a flashlight of laser light on how much room we have to close healthcare disparities in this state. For Hispanic people, 22% of the population, but 38% of COVID cases and hospitalizations. Black individuals, 5% of the population, 7% of the deaths. Completely opposite of white people, are 68% of the population, only 38% of the COVID cases. We have opportunities together we can address. And I think Jill Ryan, our Executive Director of Public Health and Environment, said it best. She said, systemic and persistent racism is a public health issue. When the color of your skin correlates to the well-being and your longevity, that is a public health injustice that must be addressed. The good news, we have stimulus dollars in the governor's budget to drive better solutions and to close those gaps. And that we can work collaboratively between advocates, carriers, providers, and state agencies to address, recognize, and close these gaps. And that the governor stepped up with executive orders to make the state, as an employer, set the example for state-of-the-art how we all need to behave as employers to right the wrong and the reimbursements and the wage gaps, and to recognize where we are on healthcare disparities. Now, I went through that very, very quickly. Here's my invitation to you. In my 34 years as a professional in executive healthcare, I've never seen so much going on. So we will host a second similar to this state of reform, and I will invite you to please block your calendars on the morning of December 17th and to consider what sort of topics that you want us to address, potentially a COVID update or more on prescription drug cost control. Hospitals and CHA in a session so the hospitals can speak for themselves on how they're addressing affordability, and we are so appreciative of those efforts, or disparities, etc. We look forward to spending more time with you on the 17th on the areas that I mentioned on hospital reporting, telehealth, and the residential strike force. We have a breakout, HCPF, more information at the 9 o'clock session. With that, back over to you, DJ, and thank you again for the opportunity.
Kim, that's a whirlwind of stuff. I mean, you just went through an hour and a half of stuff in 25 minutes. What would you thought of Kim Bimestefer in 2020 when you were Kim Bimestefer in 2010 running a health plan? What would you have made of this driving force that you are now when you were responsible for the lives and the employer contributions when you were a leader at places like Cigna?
That is an interesting question, DJ. I'm 54 and I was 44-ish. I think in all chapters of our lives, we do the best we can to make a difference. And there are folks in pharmaceutical industry that are bringing vaccines that are going to save lives with 94% effective rates and 90% effective rates, and they're going to save us. And there are folks in the hospitals that are rising up to save lives. And there are folks in carriers that work every day to connect people to care, to help them live better lives and thrive, and put out care management programs to help people rise. So in various parts of my life, I've been in various sectors of the industry, including consulting for hospitals to help them reach more people and do their job more affordably and improve quality. I think all of us step up and do that which we can. And I am honored to give this presentation this morning and to try in 25 minutes cover so much. So I apologize for the speed at which I spoke, which is why we have the second session and an invitation to all to help us craft this agenda in a time that we all need to spend time solving incredibly big problems. One of my staff leaders says, we're juggling bowling balls and chainsaws, and we are. So let's collaborate together to do it better and safer.
Well, it doesn't happen very often, but sometimes we get morning keynote presenters that require coffee. I think, I don't think you require any coffee. I think you are the caffeine.
I'm not permitted to drink coffee, and I do not.
Yeah. So let me ask you this question that Lynn Jones poses, just to go back a little bit. And let me preface by saying, as you mentioned, at 9 o'clock, there will be a deep dive session on HCPF policy initiatives with a number of your senior staff, number one. And number two, HCPF is organizing an event. We are proud and honored to play a role in helping to organize that event on December 17th. We think anything that moves the ball forward on reform is a good thing, and we want to support it. Lynn's question is, how are other states considering purchasing pharma from outside the United States? What do we learn from those other states? And how do we impact or change the U.S. pharma system as a result? Any thoughts?
Sure, loaded question. There are two levels of that I'll address. One is legislation on the federal stage. So things like reducing the amount of time that somebody has a patent protection. So Humira, the #1 selling drug in this country, has had 23 years of patent protection. We have the highest cost in the country. We could save coming on 70% by importing it. So we've got to address that issue. We're allowed to advertise in this country. No other country except for Canada and a little bit in New Zealand allow prescription drug organizations to advertise. And you can't turn on a commercial without hearing a prescription drug advertisement. That goes in the price of our drugs. It's unnecessary spend. Physicians should be in charge of that. Those are just two examples on the federal stage. On the local stage, the importation, what we've learned is that Medicaid, we're actually not going to save a lot of money from Medicaid. So we can learn from Medicaid policy to the betterment of employers and individuals who are covered by the private industry. So in Medicaid, we pass along 100% of the rebates. Now, our rebates are higher. They're in the 56% range, but the numbers that I said were 22%. We pass 100% of it along. We pass 100%, our costs come down. We have special protections in Medicaid. If prescription drug prices rise more than inflation, we don't have to pay that. Manufacturers have to give us more rebates to make up for that. So there are rules that impact Medicaid that we have learned by studying other countries, that if the rest of the country on the private side followed the rules in Medicaid, we actually would start to approach the same prices in other countries. We'll release a report next month from our department that help folks understand the difference between our policies and other countries and what we can do through importation and changing of our policies. It's an outstanding question, and we want to dive into that in a pharmacy session on this session on the 17th, and would invite Big Pharma to be part of that. It would be a fabulous dialogue and a lot that we can do. Thank you for the question.
So while you were talking, I posted a couple of polls. I wrote them and was pulling from what you were saying. One of them I asked, is it time to revisit and relaunch a public option plan, or should we put that on hold to wait for the Biden administration, or maybe just scrap it altogether? 41% said it was time to relaunch it. 36% said to wait for the Biden administration, and 23% said scrap the idea altogether. Let me ask you just sort of this philosophical question. Do you think that the healthcare system requires a policy intervention to get to where we need to be? I mean, how much of right sizing or fixing our healthcare system is policy, and how much of it is sort of spurring the market to act?
I think you should ask harder questions here, DJ. So let's say this. I think this is a great state, and the collaboration here. I've had the privilege of operating in healthcare in all 50 states. This state is unique. It collaborates more than any other state. That makes us different. I think there is an opportunity for the carriers and the hospitals and the carriers and the pharmaceutical industry to come to more favorable terms, defined as being in the better interest of our employers and families. Healthcare has a stranglehold on our employers. It has a stranglehold on our families. The lack of affordability means people are not purchasing it in a pandemic, which is unacceptable. So I believe the first step is challenging the carriers to work more aggressively and collaboratively with our hospitals and our pharmaceutical manufacturers to bring better pricing, and to challenge themselves to bring better pricing to the market. In the absence of their ability to come to terms and to step up and do the job that we need the carriers to do, and the public market should probably step in. And we can teach. Our retention, which is an expense factor in Medicaid, is 3.5%. We don't charge a profit margin, and we operate incredibly efficiently. We're answering the phone in less than 2 minutes. We are working through state-of-the-art healthcare cost controls, and we are able to do it for less money. Challenge our carriers to drive towards Medicaid-like expense factors. We have worked with the hospitals, and we are admittedly underpaying, but somewhere between the overpayments of some of the highest prices in the country and the highest profits in the country, our hospitals are working hard to lower their prices. Please accelerate that work. And that's a hard ask when the hospitals at the same time are battling a pandemic, which could actually breach their systems. So we are asking them concurrently to work with us on affordability, because we must have that during a recession for the good of the state's budget and for the good of families and for the good of businesses. We must have the affordability. At the same time, we have to challenge the carriers to step up and do a better job. Point blank, carriers, you got to do a better job. If we can do it at Medicaid with not anywhere near the resources you have, then you can do a better job. And we are willing in the All-Payer Collaborative to join forces to figure out how we can help each other be more cost effective. So I think the first step is to challenge the industry to do better on behalf of all of us. The second step is to invite, if they cannot, invite the public arena, Medicaid, others, the private sector, taking direction from the state to do a better job on behalf of Coloradan consumers and employers.
So I asked this other question sort of right in line with, the questions that you were sort of teeing up.
And by the way, there's a breakout for those that want to go into that debate. Commissioner Conway, some elected officials have a breakout on that topic.
Yeah. I asked, what should the target for hospital pricing be based on your comments? 28% said, let the market set the rates. That's how this works best. 18% said we should set payment as the average charge among like states. 16% said Medicare reimbursement should be the target, but should not be required. And I'll make sure you get all this, and all of our folks get all this. But and then 38% said that reimbursement should be fixed at Medicare rates. How do you think, you just sort of spoke to it here a second ago. This is a strong, by the way, 28% said leave it to the market. Everybody else said some level of regulatory engagement makes sense. How do you think about this balancing of trying to push the system to be better, to be more efficient, to focus on quality, to improve access, and yet navigate the challenges of this pandemic, particularly when what happens in a rural setting, in a hospital is different than what happens in an urban setting across, all experiences from financing to homelessness and in between. How do you sort of balance those competing pressures of wanting to push change and then having to deal with the context of today?
So I think the first thing that we do is drive for transparency, and our state has done a good job of that. We drove for hospital transparency on financials, and that was passed 1001. Thank you, Representative Chris Kennedy. And we also passed legislation that said where are hospitals investing in community investment. So I'm going to take them one at a time, and I'm also going to respond to your specifics on statistics. What's interesting is I was adding up, 72% of folks said some sort of a fixed reimbursement that the government or otherwise sets based on Medicare or another, and the 28%, which was the market driven. 16% plus the 38% is specifically fix it. So I think whenever you go down that road, you need to be thoughtful. And it's very important that the hospitals are leading this dialogue because they are the experts at their business. They know what makes up their pricing. They understand where their opportunities are. And the community needs to be in active dialogue because the community is paying for it. The community employers and community families are paying for it. And the bottom line is, it is true, Medicaid underpays, Medicare underpays. So if you set the target specifically at Medicare, I would say you're setting it too aggressively. And if you set it at Medicaid, which by the way pays just a little bit more than Medicare in this state, you're setting it too aggressively. So it's some metric above Medicare. And that's where the dialogue, where communities can come together. That's why this breakout that HCPF has, that these tools that we have created are so important. It allows the private industry to step in and recognize hospital by hospital how their pricing compares, how their profits, how their costs compared to other hospitals that are the same size and look like them across the country. And those tools allow the communities to have dialogue with hospitals, say, how long is it going to get you to where we need you to be? And if that collaboration isn't working, then yes, maybe it is time for the state to step in and set those reimbursements. Medicare is too aggressive. It's something above that. That's why we showed that slide that says, what is Medicare paying? What does that compare to the rest of the country on average that they're paying? And Colorado's higher. If the first is to get us down to the rest of the country, that's a reasonable goal in short order. In short order, we are in a recession. Families and employers need that. But then to drive, we are Colorado. We are the healthiest state. If we combine the healthiest state and the cost that drives in our market, which is lower than the rest of the country, with prices that come down below, we should have the lowest healthcare costs in this nation, bar none. Bar none. But we've got to get the prices of pharmaceuticals and hospitals in line. But that cannot happen by just the government stepping in and ordering it. It has to be through a collaborative nature. That's why this December 17th work group is so important. And that's why the tools that we put out to help communities come to that dialogue and agreement is so important.
Well, Kim Bimestefer, Director of the Department of Healthcare Policy and Financing, thank you for this 2-hour keynote session in 40 minutes. I appreciate very much you doing this with us.